So welcome to Urogynecology and Pelvic Healthcare. And today with us, we are very fortunate to have Dr.Hara Prasad Pattanaik, sir. No introduction needed, only naam hi kafi hai. So with you, now we want to discuss on this channel about regarding prolapse. A different case scenario, different age patient, which surgery is best and how to. So first case scenario, first of all, welcome, sir. Thank you for giving us the time.
Thank you.
So first case scenario, sir. So the first case scenario, patient is a 40 years of age or 40 years of age, sexually active with vault prolapse, grade 3 cystocele, grade 3 rectocele, and the vault prolapse. Now, in the previous history, at 30 years of age, she had been undergone vaginal hysterectomy.
At the age of 30?
30 for uterine prolapse, VH. After 2 years, 32 years, she has undergone again a repeat surgery. Or it was vault prolapse surgery for prolapse, same case. But now what surgery has been done, that is nothing, details are not mentioned. After 2 years of again prolapse she was. Now after 8 years she is presented now, but the prolapse complaint is since 6 years. So after surgery again, after 2 to 3 years, she had something coming out of the vagina. Now she is 40 years with vault prolapse, previously twice operated, and she is having with the prolapse symptoms. Apart from that, she is having urgency and stress urinary incontinence. Now patient is in front of you. Now how to approach and how to do this?
First of all, I will not agree with certain things.
Okay, sir.
That why at all a woman at the age of 30
should undergo
hysterectomy.
So, but we don't agree, but we know there are many
that
scenarios.
And second thing, you are telling that 6 years after the surgery, say at the age of 36, she had
32 again she had gone some surgery details.
32, 2 years
two
after.
years only after that.
We do not know what the surgery. And third thing is that at the age of 40, she has come with vault prolapse, with cystocele, rectocele, with urgency and frequency.
SUI. Yes, sir.
And stress incontinence. To me, the first and foremost thing that the surgery is ill-chosen.
Surgery is
ill-chosen and ill-done, which is the primary and basic thing which I want to tell.
Sure.
See, if you analyze the situation, so there is no history of childbirth or repeated childbirth, how many children she has got.
So she is para to live to hospital, yes, hospital vaginal delivery, and completed her family by the age of 25 years.
Okay. So that means she has not many children. She has only 2 children. Both are the vaginal delivery and it is a hospital delivery.
Yes, sir.
So we expect that it is a well conducted delivery.
Very true.
So next comes, if this the vaginal delivery is done properly in a hospital, and if she is developing prolapse subsequently, it means 5 years after the last childbirth, she is having a prolapse. That means you have to think whether there is an inherent problem with the woman for which she has got prolapse.
I just want to contradict this, means just both. Should we suspect there is this connective tissue disorder or something like inherited, what you said, or the surgery is not done, that's why it is repeatedly. If at 30 years the surgery would have been done well, sure.
That the first point I told you, you might have taken, that is a ill-chosen operation and ill-done operation.
Both, okay.
So that was the first thing which I told, that I do not agree to the treatment protocol or surgical protocol, what has been done. So now that what I want to say, that if she is a normal, healthy woman, completed her family at the age of 25 with 2 children at a hospital delivery, that means it is a well-performed vaginal delivery.
Yes, sir.
That we have to accept.
Yes,
next thing, if it is so, she has not multiple children, it is not a repeated and in a frequent interval, which we suggest the causes of prolapse, as we have read in our undergraduate class. So we will think that along with this, yes, of course, the primary surgery must be at
fault. It should be the best surgery.
Yes, and in this case, I anticipate or I expect that the primary surgery has not done or not performed properly. if it is being, why she has prolapse at the age of 30, when she completed her family 5 years and both vaginal, that I want to emphasize, whether there is any congenital defect with the woman or a connective. We do not come across connective tissue, very few.
Wow.
So we think that there is a condition called nulliparous prolapse.
Yes.
It is a pre-existing condition. The woman might have
previous only some degree might be there. It has been worsened by pregnancy and delivery.
So pregnancy and delivery, that will come to your mind. So it may be there, it may not be there. It is a rare case maybe, but we will expect that woman having this at the age of 30 and undergoing surgery, maybe there is a congenital prolapse. That is the point number 1, where there is a inherent defect in the supporting system of the uterus. The ligaments are to be blamed for which this has occurred. And second thing, what surgery has been done subsequently, we do not know.
The details are not there. Might be, I think the sister something might be
maybe
done. That's
so the same patient has come to the doctor again.
Now at 40 years, now again, what to do with urgency, SU and prolapse?
Now at 40 years, see, you have to assess the woman in a proper way. She has 3 compartments.
Okay,
anterior compartment, you are saying that there is cystocele. Posterior compartment, she has got rectocele. And middle compartment, she has got vault prolapse. Along with cystocele, she has got stress urinary incontinence and urge incontinence. So let us divide the stress part and the urinary problem are separate and keep the vaginal or things different. So first of all, but we are taking the patient in total.
Yes.
So basic investigation has to be done, that I need not tell. But you have to give more importance here for urinary incontinence. And the first thing to be excluded, an urinary tract infection.
Very true.
An ultrasound preoperatively to see the
void
residual urine has to be taken into consideration.
Ureter and kidney changes, if any is there.
That you have to see. Very rightly you have told that there might be some urinary kidney or ureteric changes in form of hydroureter and because of the previous surgery. Right. So once they are excluded, now you come down that this is a pure or a genuine stress incontinence along with this. And the first thing is that you have to do a repair or a vault prolapse. And there are many methods are available. You can do abdominally, you have to do laparoscopically, you can do vaginally. The basis in all these things that you have to pull the vault.
Yes.
To an upper level.
Yes.
And fix it somewhere.
To the bony structure or like that.
No, we do not fix with any bony structure because ligament attached to a bone. So ligament attached to a bone.
To a static structure.
So that it will never give up or give in again to come down. And mind you, one more thing, the patient is thin, asthenic, poor nutrition. There may be a cause of repeated.
Patient is obese, BMI is 31.
Obese. So in that case, this is not in the consideration. So now comes, how are you going to do? So in a laparoscopic method, in an abdominal method, they do a sacrocolpopexy. They fix it to the sacrum.
Like anterior.
In laparoscopy, yes. And they use a non-biodegradable or suture material or tape. Now tape is out of question. Many people are still doing. They are using a mesh and fixing it to the sacrum, and laparoscopical they are fixing into the sacrum either with a clip or what they say tacker. So that is done. So as a vaginal surgeon, I feel it is easy and convenient to do vaginally. And the structure which we fix is both the uterosacral ligament.
Okay,
the operation is quite simple. So
listen the words carefully by doctors, sir.
Nahi,
It's
nahi.
simple. Operation is very simple.
Yes.
Ligament
all those
suspension.
people who are doing conventional ward mayo hysterectomy, the same procedure had to be followed. Close your eyes and think how I am going to do a ward mayo hysterectomy. So
And
what
do
do you
it.
do in advanced hysterectomy? Anterior colporrhaphy, posterior colpoperenorrhaphy, and hysterectomy, removal of the uterus. Okay. So similarly, you give a triangular incision, or many people give an inverted T incision, right? So you remove a triangular flap on the
From the apex and the posterior part.
Yes.
Yes.
Anteriorly.
Okay.
Anteriorly. So what you do? Put your 3 alleys or tenaculum will be held, one below the external urinary meatus.
Okay.
Urethra. So 1 centimeter below. And the two will be lateral.
Apex,
As
at
you
the
do,
level of water.
Bas.
As you do the cystocele
repair. So when you remove a triangular flap and try to retrieve the mucosa from above downwards.
Okay.
If you are in the correct line of cleavage.
So just like leaf foot, you retrieve this. Okay.
Leaf foot is
that is common, but the mucosa in that way we have to
there should be stripped.
Okay,
of the antevaginal wall. So you have a triangular in places like this.
Yes, got it.
And this flap which is hanging down, you have to continue it posteriorly with a rhomboid separate. Inverted or a V-shaped incision.
Incision, got it from that.
So
that affects to the posterior part,
a rhomboid separate
diamond shape
tissue
this will be there.
Will come out.
Got it.
That finishes.
This
and the base two angle are there. Now comes, you have to separate the bladder from the lateral vaginal mucosa or wall. So what you do? Use a knife or a scissor,
or a
trim this mucosa and
from
move
all
the bladder
corners.
medially.
Yes,
so once the bladder is mobilized sufficiently and the bladder vaginal mucosa are free, now that you can see, what you do in a vaginal hysterectomy, you try to lift the bladder and pull the cervix because the uterus is there and try to give an incision
to open
or cut the uterovesical ligament.
Okay.
So there is no uterovesical ligament because there is no uterus here, but the ligamentous or fascial attachment are still there. So what you do? You try to dissect it out. You have already given an incision. You try to separate. Once you try to dissect that part, you will be able to feel the thin peritoneum in between the rectum and the bladder.
Very true.
Once
open that.
The peritoneum is opened, your job is done. So at this stage, there are two things you are worried for. The first thing is that am I going to injure the bladder? Because I am not able to get the peritoneum.
Yes.
But once you try to dissect it out, try to lift the bladder up and rectum down, try to pull both the structures. Just pull it, separate it, and you can see the mucosa in the peritoneum in between. And the structure which will give in is your peritoneum.
Okay.
So once the peritoneum is open, your job is done. And one thing you must remember, do not go too posterior because you are likely to injure the rectum. So, but God has given a pad of fat.
To identify, recognize, yes. You see the yellow color fat. Yellow fat belongs to the bladder and the bowel.
Don't go towards that direction. That is your guide. So when that is done, the peritoneum is open. When the peritoneum is open and you have to separate it, make it bigger. Once you make it bigger, so you can identify that this wide peritoneum has a neck above it.
Okay, got it.
What is coming?
That is the sac.
That is the neck of the sac. So that is the point where you are going to give your stitches at the level of the neck.
Okay.
Right? So once that is done, second point is to identify the uterosacral ligament. So many people see that how do I identify the uterosacral ligament? Try to find it out on the lateral side of the opened peritoneum, and there will be thin, redundant and black colored spots to be seen on both the sides.
Thin and black colored. Okay.
So, and if you stretch it, you can see a line coming along from above. And that is the uterosacral ligament. It is on the extreme lateral on both the sides. Try to hold it from there. And once you have hold the uterosacral ligament, if you try to pull it, it will not give in. It will not give in. The Alice will still hold it. It is strong. But if you have hold any other structure other than this,
it will give away.
Right? So your job is done. And see
which other structure can be which can be holded?
The first and the other structure is peritoneum, the fascia, lateral to this or medial to this.
So we can easily identify uterosacral because not given the tough feeling will be there.
Yes.
Okay.
Second thing is that if you do not try to hold a bigger tissue.
Small bite you take.
Small bite you
Long
take.
Alice with fine Alice,
small
small
bite.
Alice.
So if you are holding too much of tissue, that must contain the rectum with it.
Something can be complete.
So, right. So do not, and you have to give a bite, and you are causing a.
So before giving the bite, how much area of uterosacral should be dissected?
There is no need of any dissecting.
Okay.
There
just
is no need of
identify and hold it with a pull it.
Right?
Okay, so this means nothing.
That's done.
Okay.
So once that is
at the
done,
level of ischial spine, higher up.
The thing is that I will tell you the difference between a sacrospinous fixation and the uterosacral. So then once it is done, then you are taking a bite. We do not use non-absorbable suture. Okay. We do not use like Prolene. We use Vicryl or PDS. That is well known. If you have got PDS. No, I will tell you. The threads do not give you strength. The threads do not give you strength. Your body tissue gives you the strength.
Okay.
It's like that the chain will be there, but that will not cause any problem. So once you are using a PDS, take a bite. Start, if you are right-handed person, start from the left side of the patient.
Okay.
Take a bite on the uterosacral. Take a bite on the uterosacral ligament and go high in the center, as high as possible, up to the level of neck. Only the peritoneum are holding. Take a bite again. Take a bite again. Pull the right side uterosacral ligament in your left hand. Take a bite in the uterosacral ligament.
Now, this here when we are doing the right, it's from medial to lateral. Okay. No issue.
I am a right-handed person. I am starting with the left of the patient.
Okay. Lateral to medial. We took the peritoneum as high as possible.
Then you go medial to lateral.
Okay, that's
then you go up. Then you go up. Then stitch. Your stitches
you should take the anterior purse string type.
Yes, it is a purse string suture, and always aim that I will be taking the bite. You can take uterosacral ligament at a lower level, but it will be on the purse string at the level of the neck. But you say you can identify that the narrowest part which is there.
That should be the purse string. Uterosacral you can take below down also.
You can take,
but it should be at least almost near level of ischial spine.
Almost. And try, if you are taking this bite, do not take a deep bite. Take on the
peritoneum should be this superficial.
Peritoneum along with uterosacral ligament. In all other places, it is the peritoneum only.
Okay.
So then you tie it.
Tight first.
So tie it, keep a long thread and tie it and push it so that it is strangled at the level of the neck of this.
Got it.
Now leave it.
Okay. Hold it.
Now leave it. So now what will happen? Now I will say once that is done, you can do a purse string closure of the peritoneum is closed now. So you have to do closure of the bladder. So give a purse string suture. If the bladder is big, then once it is done, you can give a side to side incision on the bladder fascia from one side to the other, the way you are doing. When that is done, cut minimum level of tissue possible, then trim it and give a continuous suture in the anterior vaginal mucosa to close the procedure. Anterior colporaphy is done. Before closing this, you have to bring the two threads out.
From the external
the way you do, you bring it out from both the sides.
From the needle, eye of the needle.
Yes. Once it is done.
At the lateral wall.
Now once that is done, you are closing the anterior.
In this whole process, when are we doing cystoscopy or no cystoscopy?
Till now I am not doing cystoscopy. No, not required. So then what happens? Then you do a perineuraphy to complete the procedure. Unless the perineuraphy is done, you will not get proper vaginal length. Well, after closure, you can give a tie and pull it as high as possible. Then you do the perineuraphy. So now comes the difference between a uterosacral ligament fixation and a sacrospinous fixation. Imagine the level of the ischial spine. It is below the level of at the level of internal os.
Okay.
Ischial spine is at the level anatomy. Internal
cervix, yes, very true.
So, and the vault, vaginal vault in a non-pregnant or a healthy woman in the reproductive age is above the level of cervix.
Yes.
Because cervix is protruding out of the vault. So, vault is above that. Right? And then what is happening? So, when you are fixing it to the ischial spine, you are fixing the vault at a lower level from the normal physiological position. Think again. It is at the level of internal os. Ischial spine is at the level of internal os. And the vault is normally in a pre-surgery, pre-operative period in a healthy woman.
It's above it.
Above the internal os.
Non-physiological we are doing. When we do with hydrosacral, because we took the peritoneum high up neck cover, so it's a physiological. That's the main difference.
That is one. That means you are fixing the vault at a higher level, which is corroborative or similar to a normal woman in the reproductive.
And again, that's why you get the length also, caliber of vagina is also maintained.
Second thing, you are not fixing it. You are fixing it to one of the sacrospinous ligament. So either you are fixing it to one side or fixing it to other side.
Right.
Normally, we fix it on the right side of the patient because you are
we are comfortable. Right.
And second thing is that the large got
sigmoid colon.
Sigmoid colon is there. Yes. There is a chance there. So you always fix it on the right of the patient on your left side. So what happens? The head is the vault. You are pulling it to one side. In a uterosacral ligament, it is straight in the center, but it is going to opposite side, one side, or the right of the patient. Second thing, if you consider the pain part is more. Third thing is that identifying the uterosacral ligament, dissecting out the uterosacral ligament is difficult in many cases. Many people blindly stitch it in the uterosacral ligament. Here, you are seeing the uterosacral ligament clearly. But finding and identifying the sacrospinous ligament is difficult because you are putting your finger, dissecting out, and then you find the tip of the ischial spine, and then you try it, then retract it with a two speculi and identify this, hold the tissue in between, try to pull it out and say this is the sacrospinous ligament. That is more difficult. So this is more physiological, this is central, this is at a higher level, and this is simple to perform. So why not do it? And you can do it. And once it is done, then the entire procedure is easy and it is done.
Okay. So
next comes whether you should repair for stress incontinence or not. There are two options. Many times we find if the repair is done properly, the stress component is gone.
Okay.
Either you can defer the operation, do not put her another tape because here is a procedure
high chances of recurrence.
Here is a procedure where you are still using a mesh, a tape we are using. Of course, many people are using autologous tissue like rectus sheath or things like fasciolata, but we still are happy with the tape or a mesh. So you can defer it. You can see for yourself whether the patient is improving and has no stress. The majority of cases you will say that patient will be improved upon a stress part. So there may not be any necessity, but if you are seeing that patient is still coughing, sneezing, sitting, laughing, she is having this,
you can
do it in interval procedure
or in the
you can do the same sitting.
Okay.
That finishes the things.
So now same petting, what you would like to suggest and prefer, TVT, TOT?
We always do transobturator tape. That's
outside in, inside out.
Simple. And that is more simple, even though this TVT is more physiological again, that is more ghastly. The purpose of me telling this, try to find simple steps, try to do it in an easier way, try to find out which is less morbid to the patient and easy to learn from the person and more physiological, more things. So if you do a TVT, it is, of course, it is physiological, but it has a blind process, chances of injuring the bladder is there.
Bowel,
and think
vascular
that
injury.
if you get the same result, same benefit
in TOT, then why not to do that?
Why not do it? That's the thing.
So any chance of groin pain when we do outside in, or what's your
for TVT or TOT?
TOT outside in.
No. The thing is that groin pain is not result for the surgery.
Okay.
Groin pain is when you are going deep into it
and
taking
nerve.
this, and you are injuring the nerve.
No.
It causes. See, the procedure is such that you are taking the bite ekdam extreme outer quadrant where the vessel are much above there.
So there is a gap.
So there is a lot of, you are in a free space. You are in a safe zone. So even if you try also, you will not do injury to the nerves or vascular bundle. But if you are too callous or too complacent, there is a chance of doing this. So that's all you should say.
That's good. So, sir, you discussed very nicely. Before taking the patient to the OT table, the patient is in front of you and the patient has a lot of queries in this.
Yes.
2 already operations she has underwent. The subject to a 3rd operation. We can't say that first operation is not good done or the surgeon. Yes, we can't say that. So how to tell the patient, how to convince it? Because that's again a difficult part. She has undergone already 2 surgeries and now she has come. So
the first thing before telling anything to the patient, you examine the patient properly. Whether there is a congenital defect, whether there is a tissue defect and everything. You have to do this. That will help you to tell the patient in much confidently.
Yes,
no, madam, this has been done. Now we are taking a newer technique. We will give you the best result. You don't worry for that. Of course, you have undergone surgery twice and that is there. But this system will give you a better result. We will do that.
Any advice to patient for the future? The patient has chances of recurrence. There is always a tendency, not in the great hands.
Always tell that patients should recover properly.
Should recover. That's a bit the recurrence was what? Any advice to avoid this so that the recurrence chance? Always patient asks, but because anybody who has done before, they also reassured the patient that they will be good. So what's the patient?
There is a basic thumb rule in any surgery. It is never the suture which unite the tissue. It is the opposition of the tissue and they unite themselves, they heal themselves. Similarly, when you are giving a skin stitch, you keep the stitch for 7 days and then you remove the stitches. Then it automatically heals. This is applicable to everything.
All the surgeries.
They join in 120 hours. 5 days is enough for the healing of they join. But the tensile strength, after that what happens? The fibrous tissue goes from this end to that end and they close and they bundle and fuse together and give us a strength. This strength comes in 90 days. This strength comes in 90 days. After 90 days, see, the wound will normally have dehiscence unless she is frail, she is a nutritional deficient or other
protein
things.
Deficiency.
Grave anemia, all these things. Otherwise, it will not.
Taken care of,
so that is the concept. We are using Vicryl, which takes around 90 days to melt. So that after that, the strength is already there. 5 should be there. This, even if you are giving a proline will stay for a longer time. You think of giving a non-absorbable suture where you are expecting that this should be there. Like a stress incontinence. You are giving a tape. So this will work as a hammock. This will work as a hammock.
Suture is not, there is no use of suture. I mean, suture is just
keeping
to take it. Main is the tissue healing in uterocycle. Got it.
So there are few indications where we use non-absorbable suture. I use non-absorbable suture for microsurgery, for doing tuboplasty. We do it. 60 proline, we use it, and we want that these prolines should stay because they will waste. Otherwise, once you should advise this patient that please take in good food, poor nutrition, corrected anemia. This is for general well-being, general health. Second thing, avoid any pressure to the abdomen, which will have a pressure on the
vagina, bowel, bladder.
Vault again. So avoid constipation, avoid cough, and these are things which you always tell in case of hernia and prolapse in other cases as usual. And fourth thing, the most important thing is that take adequate rest and dehydration so that this will not come up. Normally, this should be a successful operation. If the patient is not asthenic, patient is not grossly anemic, patient is not grossly malnutrited, and she does not have any congenital ligamentous defect. This is sufficient enough for the patient to heal properly and remain healthy afterwards.
Now, sir, in this uterosacral I want to ask, there is one peritoneal and one extraperitoneal approach. Yes. In this case, you have opened the vault, what you have explained as a
peritoneal approach.
This anything extra, because again there is a risk, as you said, of bladder.
What you say, there are two surgeons who do extraperitoneal approach. One you have mentioned about Dr. Umarani Swami, and the other one is Byomesa. Okay. Byomesa is from Ahmedabad, and basically is from Patan. So what they do, they will not open the peritoneum.
So again there is risk now, bladder and most of blood. I think bowel is also,
what I think,
because previous
surgery. Once you
get habituated,
dissect it out and you push the bladder and bowel up, identify the ligaments laterally in the extraperitoneal part, and you can give a stitch, then the opposite.
So how to take without peritoneum? How the, because it should strangulate, or yes, we should do figure of it. We should shorten the length of the ligament.
The ligament are tied in the midline, and they repair it, taking the fascia from both the sides and cut the redundant tissue. Okay. That is much simpler, take a less time. But the thing is that the same thing that it may not give enough support to this, and I have not come
extraperitoneal.
Yes, and I do not know. This is okay for leaflet surgery because you are closing the vagina, and the elderly women, you are closing the vagina, so there is no chance of any further prolapse because everything is closed.
Got it.
So everything will be there. But if you are not doing a leaflet procedure and you are doing this extraperitoneal, to me, it feels that it may give way. Subsequently, it may happen. Byomesa and I have done a number of surgery together. He does in his method, I do in my method, and we do not have a comparison data. Anytime you meet Byomesa, you can ask; he will explain you much better.
Hope to meet sir soon. Now, sir, in this, again, cystocele, as you said, you can take a purse string, but if it's big, you can take from the one end to the other end.
If it is big, take a purse string. Okay. If it is okay, you can close it. Normally in vault prolapse, it is always a big one.
So you take the purse. So you don't need to take the center fascia in it?
Normally, bladder, you are not stitching the bladder.
Just a facial defect.
The
site specific.
Inside is the endothelium, middle is the muscle, and the outside is the fascia. The superficial part or a serosal part. So you are taking serosal part and giving a purse string suture. Never try to take a bite on the bladder itself.
Not the bladder, sir, but the facial defect, the center part, like centrocystocele, there is a defect, like what we say nowadays, site-specific repair. So in the purse string, how to take that defect?
See,
or we should first close the facial.
We are not. You are telling another things. So what they do, take the second part you are doing this. First you are taking a bite all along the bladder in a circular manner, in a purse string suture, taking the fascia and the serosa together.
Okay, yes, got it.
Right? And closing it. When that is closed, the bladder is pushed inside. And then you are giving a stitch side to side. Side to side. Okay. Intermittent suture and at 3 or 4 places depending on the length available to you.
That's only I'm saying. Shouldn't we do that intermittent part first and then do the purse string?
If you do a intermittent
part, that will also go inside. It will also help.
No, if you do a intermittent fast, there is no bladder will be coming out to be sewn.
To be purse string.
To be purse string first, then side to side.
Okay. And the paravaginal repair also will get by this because you took the purse string from the first and the central both will get corrected from this.
Yes.
Okay, this is now we'll come to second case scenario, sir. 62-year-old female. She is presented with vault prolapse, cystocele, SUI, reclusive vault prolapse. At 50 years of age, she has undergone vaginal hysterectomy. The same case scenario with urgency and SUI both. So again, we should go for the same procedure, high uterine cycles at the age, the thing like she's not sexually active. So should we go for Leaffoot at this young age? 62 is nowadays also not that old age, because Leaffoot again they have the tendency of urinary incontinence post procedure. The same procedure.
No, this is not for me. This is not the time for a Leaffoot procedure.
No, that's only 62.
Even though our women in the eastern part of the globe are sexually active, women in the western part are sexually active at this age also. So they want their sexual function to be retained.
But if she does not want to retain, should we offer her Leaffoot or no?
You can offer.
Because the reason what I want to ask is after the Leaffoot, the long term is there chances of urinary incontinence. Suppose we offer at 62.
I will tell the negative aspect of Leaffoot. The thing is that what you told one part. Second thing is that in a vault prolapse there is, if even we do a Leaffoot operation for women with uteri and at the extreme age where they are not fit for surgery. So we do a vaginal closure procedure which we call as Leaffoot colpoclysis. See, what we do in a Leaffoot operation, either you can do in a prolapse with a uterus
inside or vault prolapse.
So the basically thing which we get that everything inside, you just close it,
high perinorrhaphy with high
close it. So uterus is there, cervix is there. The chances of cervical pathology, cervical infection will be there.
So, but in case of vault prolapse?
It will not be there, but I am coming to that. There are other things. So that part is there.
Yes, that is
always cervix, you are not ruling it out. Bulbovaginal discharge will be there.
Okay.
In a case, again, in a case of vault prolapse, even though there is no cervix, as because you are closing it, keeping a space inside, there is a potential space remains between the vault and this thing. Then that if it is this space, dead space is more, there is a chance of infection and vulvovaginal discharge and everything will be there. You have to correct it. Third thing. So otherwise, in a healthy woman without any diabetes, without any other pathology, this will give a good result, at least to tide over the remaining period of her life. But 62 is no age for that. So I think doing at this stage, colpoclysis at 62, even in the Western world or Western world, Eastern world, it is not.
Not to be done. So any stage or any point where you prefer sacrospinous fixation over high uterosacral or no?
You can do. I was doing sacrospinous fixation earlier. Once I got a better method, a simpler method, easier method, I opted for this. Okay, all of us were doing TVT and we are seeing and we are doing cystoscopy. Here we are not in a TVT. Cystoscopy is a must.
Must, yes.
But in a TOT, it is not necessary.
Not required.
Similarly, there is a finacy is going on. In every science.
And so even we as a surgeon also always.
Yes, we are going defining ourselves. Some procedure thinking that it was very mandatory, and now that after so many years of research, we found that you can bypass certain step. It does not give any added benefit. Similar things are happening. So maybe some novel way will come in future, so that you use some glue or paste or something, put it there. Medicine will come that will strengthen the ligaments. There is no need of any surgery. See, this comes an out of box idea.
Innovation,
and if you think that is he is telling something fantasy, this fantasy is
maybe
proven
too
correct.
Very
right? So this happens.
Can happen.
The days were there where we are doing a lot of peptic ulcer. We are doing a lot of peptic ulcer operation in my undergraduate days. Everything there is 4-5 GJ vagotomy or things like that. But nowadays you do not see anybody doing a gastrojejunostomy and vagotomy for peptic ulcer.
Drugs have come back.
Drugs have come back.
Very
true,
so
days will come. Two things will survive: a preventive medicine and a drug. So this will be there. Maybe 10 years down the lane, somebody will come. Sometimes you never know. Come with certain things that you give this, the ligament will be tighter, the vaginal mucosa will be tighter, or there will be closure of the vulva. You need not do a leaflet operation. I do not know. Time will tell. Maybe in the next generation, in near generation, you will see things have become there. So the concept you should remember. The tensile strength of the tissues and the strong strength of the ligament will support it. If anything which does not help the strengthening of this by fixing the ligaments, the procedure will be a failure. That's the simple. And the simple physiology and simple anatomy will tell you that yes, this is going to help, this is not going to help. Whatever surgery you do in a congenital defective person, this is likely to give way.
No, congenital.
That is the thing.
So if the only congenital prolapse is not planning to discuss this, but if the congenital with surgery you would offer with uterus in situ, the same patient, if the first patient which had come at 30 years with uterine prolapse.
We do see in a congenital prolapse, you do not find a cystocele or a rectus.
Only uterus, cervix might
descent.
Be decent. Cervix might be elongated.
The thing which you consider, you have rightly told, cervix might be elongated. There are two distinct entities. One is a congenital elongated cervix.
Okay.
The other is a
intravaginal
congenital prolapse. How to differentiate between two? In a congenital elongation of the cervix, the cervical length will be more.
And C and the D point, it will be
right. It will come out of the introitus, it will be seen. But the position of the uterus is at the normal level. The ligaments, everything. But in a congenital prolapse, the position of the uterus come down and the length of the cervix is normal.
Normal, and C and D point by transperineal ultrasound also.
This you can know. Descent of the uterus with normal length cervix is a congenital prolapse. Non-descent of the uterus with elongated cervix is a congenital elongation. Simple.
So in that surgery, what you would prefer, sir? The same patient who had 30 years of age.
We actually do not. We use a autologous tissue rectus sheath. We repair it.
Purandare is
similarly,
modified.
Yes, modified Purandare we do. And now also doing laparoscopically, it also can be done. And we do with opening the peritoneum, stitching it, taking a rectus sheath, this, and tying it to the anterior side of the cervix and fixing it to both the sides. This is what we normally do in a Purandare.
Anterior, posterior you prefer?
Right.
You prefer anterior?
Anterior only. Anterior only. But remind it, she should, if she delivers, there should be a cesarean section. Otherwise, operation is going to be failure.
Now the last case I want to discuss, 77-year-old female. At 55 years of age, she has undergone vaginal hysterectomy for uterine prolapse. Now she is 77. At 67 years of age, 10 years back, after 55, 67 of year age, she has gone surgery for vault prolapse. Now details, we don't know what.
She has gone for vault prolapse.
Vault prolapse. Don't know whether cystocele repair. Now that was at 67 years. Now she is presented with urgency, SUI, cystocele, rectocele, vault prolapse, and fecal incontinence with mild degree of mucosal rectal prolapse. So dual rectal and 77 years of quality of life is a hell. Now what you prefer the
this is a difficult case for the benefit of the patient.
Sir, कुछ तो difficult बोला.
Surgery. You see, you need a combined approach. By a general surgeon or a gastro surgeon, colorectal surgeon, along with this. Say, if the patient is stable, if the 77 is not a very old age, if this is fit for anesthesia, she is fit for surgery.
So with surgery.
Okay, if she is fit to withstand surgery under anesthesia, then if she is not frail, she is not asthenic, and we can always go at this. If there is diabetes control, hypertension control, thyroid control, we can do it. There are two things. Yes, a colorectal surgeon is necessary to give a better service for the patient. And here you will also see the procedure will be all the same.
High uterosacral? Or in this you want to prefer for leaflet, or should we prefer for leaflet?
Part one. Part one is that the patient, how healthy is the patient, what is the socioeconomic status of the patient and things. We give LIFTs to a patient of a poor nutritional status, a patient who is frail, a patient who is not ambulatory, strength-wise. These are the patients who are fit for LIFT operation or should be given the option of a LIFT operation. LIFT operation is a supportive surgery. It is not the definitive surgery. So, you see, the patient has a problem, she is complaining and you cannot give her any benefit, so close it. And the inside thing will remain same, inside problem will be remain same. You give something, it's just like a putting a pessary or keeping the clothes for a long time, and the patient will pass away after 2 years, why do I do a surgery? So that is the aim of this. But if this patient is strong, well built, everything is okay, you can do a procedure like this. So and the patient itself will decide whether she is fit for the surgery, whether she is not fit for the surgery, and you plan your approach accordingly.
So same patient, if she's not having a different patient, 75-year-old female patient, chronic COPD, she's having some lung pathology, same vault prolapse. 75 with chronic COPD, she's on inhaler, nebulizer, and for this whole thing. She's having SUI, urgency, and vault prolapse. Only 75 years.
And here is the case, if she is having chronic cough and these things, the surgery, if she is frail, the surgery is most likely to give way. So in what such a case, her? You can give her an option of a LIFT surgery, but always tell that unless this is
fail and SUI also may
aggravate
after the surgery. So now after we have done LIFT and she comes and again we off the tape.
If she comes out the tape,
after the surgery,
better. If and at the 77 years,
if she's bothered, there are patients. There are patients. 85, 90 also means.
See, I have a patient who operate. Once I go back, she is 75 years. She is 96 kg. She is bilateral kidney disease. She has got high diabetes. She is hypertensive, and she insists that I should go undergo hysterectomy. So I told that if you are fit for anesthesia, you are fit for surgery. And I did a diagnostic hysteroscopy and endometrial biopsy. I saw there is a fibroid polyp hanging through the os and some endometrial polyp inside, and removed them and sent for pathology. They came out to be benign. And now that we want, what are we going to do now in such a case? So the plan is that if she cannot withstand surgery or anesthesia for a longer time, she has so many comorbidities. So first option I am going to give it is a Thorma choice or balloon ablation. That is what. So similarly, your patient, you have to segregate the patient according to their physical condition, according to their complaint, according to their age, and you will decide different surgery for different. And counsel them properly, counsel the attendant properly, say that this is what I am going to offer and you have to help me this way. COPD patient, if cough is not controlled, which is very unlikely to be controlled, there is a chance that it may. So similarly think, a proper counseling is required in all these cases, otherwise they will again come back, you did the operation and it's a failure. So if they are properly counseled, take a consent form and perform the procedure, it will give a good result. Once it
failed after LIFT, then what we can give the options?
Beyond that, we do not have anything. We always say that you give a undergarment. So we gave them, we advise them to use adult diapers and undergarment and ask them to have a perineal hygienic. We give them lifestyle modification. We say that you have a biofeedback. Yes, there are biofeedback. There are levator and strengthening exercises, Kegel's exercises. And for elderly women, instead of going for a surgery in all cases, you should do these first.
Conservative first.
Scheduled toileting, then close to this day, then you should have a regular timed toilet. So every 2 hours, whether they have a urge or not, they should go to the toilet.
And also, suppose I was just like a 65 years patient with Vault Prolapse with mixed with SUI. Now, as you said previously also, we can offer in the same setting or we can wait because CYSTOCELE itself will correct. Now, my question is, as the age increases, there are likely that she will have some comorbid condition also. It may be low BMI, high BMI, diabetes, hypertension, and other comorbidities. So, when she is having stress incontinence present, the patient will ask her, what you feel better, doctor, you do. So, should we offer her that SUI anti-incontinence surgery, or we should wait like CYSTOCELE may correct and again subject her to surgery?
The degree of complaint, degree of pathology,
which is bothered most. So, if that is bothered most, offer at the same time, or you can tell if she's not bothered, you can wait and watch it.
Yes.
That's the most important.
If it is a mild variety,
second and last
if it is a mild variety, then this primarily anterior colporrhaphy will help her. But if there is a severe degree of stress, then better to stress in the same setting rather than anything else.
I'll ask from here only. Sir, any
vaginal surgeons in the world, now many people think that vaginal surgery has become obsolete. Because in the era of laparoscopy, everything people want that it should be done by laparoscopically. So things which are easy to perform vaginally, I am an endoscopic surgeon. But the surgery which is possible or simple and can be done vaginally should be done. And we have a society called Society of Vaginal Surgeons of India, or SOPSI. And the headquarters being in Cuttack. And we have a new president, Dr. B.P. Piley. We have 5 vice presidents, east, west, north, south and center. And for your EU commander, Bhatinda comes in Punjab. And Dr. Sonal Vatla is the Vice President North Zone, and we have Umarani Swai as one of the executive member, along with Dr. Rajshree Jain. And these are the people who are responsible to propagating. I am coming to Delhi on 3rd of October. I am a member of SOPSI, and we have so many workshops going on in different places. We have video session, we have lecture session, everything. So till then, goodbye. My membership fees is 2,500 now, and till 31st December 2024, from 1st January, we will like to hike it to 5,000 after that, and naturally we have more members, and that's all. Thank you.
Thank you, sir.